So, which group of providers, and I have providers in quotes because at least one group on there is not thought of as a provider usually, which group of providers, when they look at client outcomes, has the best overall outcome in therapy? Anybody want to take a guess?
I want to say I read something that they're all about equal when the client is discussing their outcomes.
Yeah, so we're looking at the outcomes when they measure client well-being over a course of therapy. Does, in essence, what matters? Does it matter how much experience a therapist has or not? And I think what you're getting at is, and the answer is, that none of those groups have better outcomes. Does that make sense? Even if it doesn't really make sense, I think it makes sense what I'm saying. So, quiz question number 2. What matters or what significantly affects outcomes of clients over a course of therapy? The amount of experience a therapist has, the amount of supervision that they've had, and this is a kind of a key one, a specific therapy targeted at a specific diagnosis. So we hear a lot about CBT for depression, or 12-step facilitation for addiction, or DBT for borderline personality. So the specific treatment targeted at a specific diagnosis, whether or not a provider trained in 1982 versus 2022, what degree or discipline the provider is from, and the continuing education. I don't know if you're getting credit for what's happening today, but the type or amount of continuing education. Maybe you can see where this is going. Any guesses as to what factor matters?
I would say none of the above, because depends on the connection and how the client react to treatment.
You want to come on up here and teach your class?
Just guessing, you said yes, so I just throw it out.
Yes, so that is the case, that none of those factors has an impact on the outcomes of a course of therapy. And it's been studied fairly rigorously.
Yeah, the therapeutic relationship accounts for the bulk of the experience and change.
Are you professor? Are you? Okay. Are you?
Dr. Rivas.
Are you Dr. Rivas?
Dr. Rivas.
Nice to meet you.
For you, I'm Mita. For them, I'm Dr. Rivas.
Well, I'm Dan. Okay, so okay. Is anybody surprised by this? A little bit. Say something about that surprise.
I think that my answer actually would have been a combination of all the above, because every client's different and every client needs a different thing, and every person that's suffering through a substance abuse issue needs different care. That's why it's so complicated, because every single one of them is different.
We try to fit the treatment to the client, right? And that's at least in part what feedback informed treatment is about. So maybe a better answer is none of the above and all of the above. Does that make sense? Thank you. So just to sort of carry it a little bit further, so we started the first, there's a statistical procedure called meta-analysis, and the very first one that happened, actually in all of medicine, actually happened regarding psychotherapy in the mid-70s, where they were able to actually determine that psychotherapy outcomes are really quite good. client outcomes in psychotherapy are quite good. The interesting news is that over the 45 years since that first meta-analysis, there is no evidence that they've gotten any better. So anybody know what that picture on the left is? That's a chart room. That's a chart room that I used those chart rooms up until about maybe 15 years ago. So you think about psychotherapy in the 45 years not changing. So a chart room has gone from what's on the left there. That's the chart room right there. You know, millions of data entries are in that computer right there. And yet psychotherapy outcomes have not improved over the same period of time. Another sort of surprising fact is that when they measure outcomes for people in training, over the course of their training, outcomes don't improve either. And not only do therapist outcomes not improve over the course, over a long period of time, there's actually a slow decline. On average, therapist outcomes actually decline a little bit, like air leaking out of a tire. So, any ideas why this is? Anybody have any thoughts about it?
Burnout?
Say some more about that.
People get jaded and stop.
Compassion
practicing the best
fatigue.
Yeah.
Any other ideas?
I was gonna say something similar, just that people don't necessarily have there's not a lot of support around like mental health and counseling and therapy and things like that, so without the support and without kind of backed up research, not much is gonna change.
Very good point. Very good point. And part of it is, and we'll get to this, is that we don't necessarily get a lot of feedback on the outcomes of what we're doing. It's hard to improve that way. So one thing does improve with experience of therapists over time. Anybody know what that is, or anybody have a guess?
Humility.
Maybe a little bit. That's not.
Connecting to clients, better therapeutic relationship, connecting to clients, more open, wider communities.
So what I had in mind was confidence. With familiarity, with repetition, we become more confident. And that confidence or that repetition leads to something called automaticity. It's human nature. It's something that our brains do so that we can become more efficient. We don't have to think as much about how we do something, so we can commit resources to other things. The problem with automatic behavior is that once it gets engaged, it's hard to notice. It's hard to make changes. And repeating patterns can go on for years, sometimes even for a whole career. So I don't know that how to address humility that was mentioned. I would say that I believe that feedback-informed treatment is a way to remain humble in the way that you approach therapy, if that makes sense.
Well, it almost sounds like you have to have a good roadmap to begin with, so it becomes good muscle memory. So maybe that's the humility link. Because taking feedback is really tricky.
Amen.
Really tricky. Yeah?
Amen.
Yeah. It hurts.
Well, speaking of being on what you said, like if the BDS or whoever our training body is, if there's like a standardized, you mentioned roadmap, and if we're getting audited as licensed clinicians or something to see if, I guess that's where I'm thinking of like a given feedback that we could implement. I don't know if that's what it looks like now.
Well, I'll have some suggestions towards the end.
Okay.
And my theory is, and it's, you know, fairly blunt, is that you don't know crap. Oh my God, you just told us we don't know anything. I wanna get up and leave right away. So I'm gonna spend much of the rest of the time convincing you, or trying to convince you, that this is actually a good thing.
Can we take a picture in front of that before we all leave? Because I feel like I'm trying to communicate this. And I've lost someone else's name.
Well, because, I mean, you know, if we look at, you know, the research that I've talked about, you know, so, you know, I spent my career learning a lot of crap that didn't necessarily improve my effectiveness. So here you are at the beginning of your careers, and I'm hoping to help you learn how to grow and get better. Does that make sense? So do not hear me say that training is not useful. I would, you know, I would never stand up here and say that, you know, the first time and you know, and hope to get invited back. Training is very useful. We learn useful skills, especially empathy and listening skills. We learn useful methods. Methods are the only way to organize how we do our therapy. And FIT is one of those ways. We get to practice before we're thrown out there to practice independently without any supervision. And we get to join a group where we learn together. So training is definitely useful. So this, I almost feel like this is like the key slide in what I wanted to talk about. And I, you know, spent the last couple days kind of refining this, and I apologize for the busyness of this slide. But I believe that this is what you're doing now, as eager, hungry, anxious, ready to learn students. Am I helping my clients? I mean, it sounds maybe a little bit adolescent, but, you know, how do I get people to like me? How do I get my clients to like me? It can get scary. People are crying and sobbing and getting angry in the therapy room. How do I deal with that? How do I learn to deal with my clients' emotions? We're always told, you know, we're not supposed to give advice. Well, what if they ask for it? Am I supposed to just say nothing? I make mistakes every day in dealing and talking to people. How do I know when I'm making a mistake with a client? How do I find that out? I want feedback. I mean, I really want feedback that I'm doing well, but I want to know something. I want to hear, you know, about what you think about how I'm doing. Where can I get useful feedback? I think about my clients all the time when I'm not with them. I think about them when I go to bed at night. I think about them when I get up in the morning. How can I use my time when I'm not in the therapy room to be more effective when I'm in the therapy? How do I do that? Sometimes I get so nervous, I find myself, I don't know what to say. How do I reduce my own anxiety? I love working with my supervisors. They're fantastic. But I don't want to bug them with too many questions. I don't want to be annoying. How do I get
I think you just wrote this slide for me.
You got any to add?
I mean, all of those, like, who can I ask? Who can I, how do I do? What questions should I ask? Those are like just beginning, student, counselor. These are the more, always, helping my clients out, what, am I intentionally harm my client? So that those are like always in my mind, you know. Then I don't, does the client like me, or does it fit my personality, or could I look weird because I look different than my client? Will my client be more open up for diversity or something like that?
I don't know if you have context for this room, but almost everyone is in practicum. We have a couple internship, I wanna say, yeah, a couple internship, and then one not quite there yet, all the other. Or maybe two.
So pretty much everybody is starting to see clients. Right.
Exactly, like they're in the thick of it right now. Is that fair to say, y'all?
Mhm.
Yeah.
Do these questions resonate?
100%.
So my PowerPoint skills are not very good, but I had intended to see if I could get the questions to kind of fade away. Because honestly, I think a lot of times what's happens is these questions become less and less relevant. Maybe they're not out of the mind at all. Maybe they're not completely gone, but it's not the same. It's not the same when you've got experience and confidence. So, what is feedback-informed treatment? What is that? Well, starting in the late 1990s, researchers began collecting data. And there were various measures used, but data from clients on how they were doing over the course of therapy. It's called routine outcome monitoring, or ROM. There's a whole bunch of different measures available. I will show you some simple measures that I use in a little bit. And the specific measures aren't as important as the culture of feedback that gets created between therapist and client. It's about how the feedback guides the therapy. Feedback-informed treatment is excellent at addressing health equity and culturally responsive care, kind of what you were talking about. If you think of a playing field and a therapist with a top-down information to a client, feedback-informed treatment moves to right that balance. It amplifies the client's voice. And it doesn't place the responsibility for change on the therapist, but it does place responsibility for the engagement. I wanted to talk a little bit about the alliance between medicine and therapy. Originally in this slide I put unholy. And I stand up here, many of you know, I'm actually a medical doctor. And medicine is based on the principle of a specific treatment targeted at a specific problem. You have a streptococcal infection, we're going to give you amoxicillin that's going to treat it. You have a diseased gallbladder, we're going to remove that surgically. And years ago, in essence, and it's a complicated story, but the psychotherapy world kind of allied themselves with medicine. But this specific treatment for a specific psychologic diagnosis has not borne out. I won't go into the details, but there are a kind of study called dismantling studies, where they actually remove the specific aspect of the treatment, and it still works. So psychotherapy is more like the placebo effect than it is like the medicine effect. It's not necessarily the placebo effect, but it's more like the placebo effect than the specific drug effect. Does that make sense? And I like to think of psychotherapy as being a culturally embedded healing practice. Very different from medicine. Talk a little bit about therapist effects. Dr. Rivas mentioned the alliance. So there's a psychological researcher named Scott Baldwin, and this was done a long time ago, and I believe that similar studies have been repeated. But he did something kind of unthinkable. He took 331 clients and 81 clinicians, course of therapy, monitoring the client's outcomes at every visit over a period of several months at least. And he rank ordered the clinicians in terms of their effectiveness. And what he found was that the therapist's ability to create an alliance with a broad range of clients pretty much predicted outcomes almost 1-to-1. So what that means is that the best therapist had the ability to create alliances with the broadest range of clients. The worst therapist had the ability to create an alliance with the most narrow group of clients. And this is sort of what I would call the kicker, and that is that the client's ability to form an alliance did not matter for outcome. And it's kind of a complicated thing to tease out, but the way I like to think about it is that if you take the best therapist and find a client in that therapist's caseload that did not have a good alliance, which they're very few, they're still likely to have a good outcome. And if you take a client of the worst therapist who had a good alliance with the worst therapist, they're more likely to have a bad outcome. Does that make any sense? So it does help. Did you have a question?
No.
Okay.
Okay.
This is brilliant. Did you all understand that? Do you know what that means then?
It's all on us.
It's all on us creating that space despite any biases or thinking we're the expert. Is that fair to say, Robert?
I think so. And so I'm here to suggest that feedback informed treatment is a fantastic method to help with the alliance, and it puts more pressure on you when you're already feeling a lot of pressure as you see your clients. So bear with me. So a little bit about old paradigm and new paradigm. And I thought of an analogy. So it's my job to keep you engaged in this talk. If it's not going well, then maybe I'll think, oh, you guys got spring break next week, and you're thinking about the beach or whatever you're going to be doing. And so that's why the talk's not going well. If the talk's going great, I'm doing a bang-up job. It's human nature to do that. Our confidence causes us to overestimate and overemphasize our successes and de-emphasize our failures. Feedback-informed treatment is about trying to be realistic about that. And so I realize that I'm responsible for keeping you engaged here, just as you're responsible for keeping your clients engaged. Make sense?
Man, that's brilliant. Yes.
Okay.
I'm so glad you're all hearing this.
Yes, it is. And, I mean, I was gonna get to this later, but so I spent a 30-plus year career at Kaiser Permanente working in addiction medicine. And I retired from Kaiser, I'm still working now, so, almost a year and a half ago. And I've been using feedback-informed treatment in groups in a residential addiction facility. And I feel like a student again. I am feeling a pretty heavy burden of having to keep clients engaged. But it's a good kind of burden. It's a connected kind of burden. So, in terms of when they measure outcomes and results from feedback-informed treatment, what they find is that if it's practiced at a high level of fidelity, you can get double the effect size. You can decrease dropout and clients deteriorating in your care significantly, a third to a half. Lengths of stay get shortened, the cost of care gets reduced, and probably, maybe most importantly, or not necessarily most importantly, but importantly, and we've talked about it, burnout. Being effective, working on your effectiveness, hearing the client's voice is a very satisfying way to practice. I don't want to be Pollyanna-ish. I mean, there are a lot of pressures on therapists these days for documentation and regulation, but this is a good way to practice in a satisfying way. So how do we use this? How do we use routine outcome monitoring? Well, it's a good way to set parameters in a therapy course from the very beginning. I work a little differently from most therapists. I collect data at the beginning and the end. And I use that data to help make sure that we're on track. If what I know is going to help you, we should be seeing some positive changes within a few weeks. If we're not, I want to know about it so that I can adjust. Maybe we can add services. In extreme cases, this doesn't happen very often, but sometimes I'm just not the right fit for you. Sometimes I don't know the thing that you need. And if that's the case, then maybe at some point we get you to somebody who can. So it sets the stage for people being focused on getting an outcome. It's a great way to identify cases that aren't doing well. And the fact is that therapists actually aren't very good at predicting who's not doing well. Most of the time when somebody's made the decision that they're probably not going to keep coming, they don't tell you, and they just disappear. So this is a way to kind of keep your finger on the pulse. Very good way to be responsive to clients. I think you've probably heard about rupture and repair. I don't honor my mistakes. I don't even like to accept them, but I know that I'm going to make mistakes. And a lot of times they're small mistakes that can be corrected. When you collect data from lots of clients, over time you can identify patterns in your way of approaching therapy that can be problematic. I don't know if people have heard about deliberate practice, but it's a particular kind of practice that's being talked about in the therapy world these days. And it involves looking at areas where you fall short, what's called your growth edge. And feedback-informed treatment fits in very nicely with this. So in other words, while you're learning to do therapy, as you're learning to do therapy, using feedback is a great way to learn it. By getting feedback from the people that really matter most in the therapy room, which is the client.
I have a question. You said that, at the beginning you kind of collect data and then in the end you collect data. Would there be an appropriate way to ask, I don't know if there even is an appropriate way to ask, or how would you say, it's not even like a how do you think I'm doing, but like, would you ask it in a way like, do you feel like you're getting something out of this session today?
Yes. So, I'm getting to this. And I'm going to show you some specific measures, very simple measures. At the beginning, you collect outcome data, well-being data from the client. At the end, you collect relationship data. Does that make sense? Yeah. Good question. You're anticipating what I'm going to be talking about next. In fact, here it is. This is a very simple scale. This is the one that I use. And I think I have like 10 or 11 copies that I'll be happy to give to you. And I'll show you how you get to these as well. But this is the scale that's used at the beginning of the session. Generally, it's meant as data to be collected no more than weekly. And so what you do with the client is and the instructions are literally right up here. Looking back over the last week, including today, help us understand how you've been feeling by rating how well you've been doing in the following areas of your life, where marks to the left represent low levels and marks to the right indicate high levels. And so this is a 10 centimeter line, and the client just marks where they feel they are. They eyeball it. This is individually, which is personal well-being. This is interpersonally, family and close relationships. This is socially, so kind of outside the home, work, school, friendships, and overall, which can be an average of the other three or something else that the scale hasn't covered. In my world, I deal with people frequently with chronic pain, so I tell them that they can use that for their pain levels. Does that make sense? So this is a well-being scale. It's used at the beginning of the session. You have to remind people every time pretty much they fill it out to not focus on exactly what's going on now, but try to look over the past week. Most clients take a minute or less to fill it out. It checks all the boxes for statistical usefulness. And even though it seems very simple, I can tell you it's quite powerful.
I have a question on your scale. You said it's 10 centimeters. I'm wondering, are you putting numerical values to where they're marking it?
Nope, and clients sometimes will ask me that.
Okay.
And, let's say I'm in the middle and so I use an electronic version of this. It costs money. It's not cheap. For me, it's $200 a year. But I have all my clients in a database. And, but no, they can estimate. This is 0, this is 10, and they just check on it. If you're doing it over the phone, then you have to use numbers. It can be done over the phone.
But when you add it up, like at the end, you put a numerical value to it, right?
Well, so I have kind of purposely not talked about some of the specifics of this, but when the client marks it, I can show you, I have a ruler that I pull out, and I measure it to the nearest millimeter, so this might be 6.9, and I add them up, and they get a total score. And then you can graph the score, and my electronic program will graph the score and show, and there's, it's very interesting. There's what's called expected trajectories. So at this time in 2022, there are now millions of data points from all aspects of behavioral health on people. The initial score is key. And so where their initial score is, there's an expected trajectory if that person's going to have a successful outcome. And you get red, yellow, green. Red is off track, yellow is intermediate, green is on track. And so you have a graphic representation of how somebody's doing. It's very cool.
I think it's interesting how you're having it there versus actual numbers, because how we're taught in the education system, 10 is usually like an A or 1 is like 0, and so I think it's nice that you, like as a clinician, you're doing behind the scenes where they're just marking it.
They're just marking what they're just eyeballing.
Yeah, I kind of like that.
I'll second that. I definitely like that because I know being a client, you know, things that are like 1, 2, 3, 4, 5, whatever, I get stuck. And then I'm like 3.5.
Right. Well, there you go. So it's continuous.
Yeah. And then
You don't have to.
You can be in between numbers too.
Okay, so we this is the relationship scale. So we have the ORS at the beginning, and then this is called the session rating scale. And it's a little bit more self-explanatory for the client. That's not Barry, is it? Is that Barry Turner? Good to see you. So this is session rating scale, and this is the alliance or the relational bond or the relationship scale, and so they do the same thing. And you got 4 questions, 10-centimeter line. I felt heard, understood, and respected. I did not feel heard, understood, and respected. We worked on what I wanted to work on. We didn't work on what I wanted. I liked the approach that the therapist brought to the room. I didn't like it. And then overall, did the fit feel right, or was something missing? Well, go ahead.
Did you come up with this? Because it feels me like it's more effective directly, it's like treat where it hurts. So did you come up with this method, or how did you?
Oh, no, they're, so these scales were developed over 20 years ago. And, I mean, they were developed by certain people. I mean, you know, it's, I'm not gonna drop names necessarily, but I do have a mentor who is the inventor of these scales. Were you saying, did you have a criticism of them?
No, I thought they're very effective, but because it feel like, for example, like your medical doctor tell me where it hurts, so this is where it is. I'd be more focused and more into this part. So these data actually give you a good feeling of where overall the client is, and you can effectively focus on a certain area instead of just regular theory. You just add a whole bunch of questions.
Amen. Yeah, it's like, you know, it's a little bit like my stethoscope, right? You know, for at least the beginning one, the ORS, you know, that's my stethoscope.
I was just wondering if it's like, how do you know they're being honest and accurate with this? Like, are you asking them this in the session, and are they, I mean, cause I would just feel like uncomfortable almost with my own therapist, like necessarily saying like, you did a bad job. Like, how do you create an environment where they can be honest about this?
Such a good question. And I didn't tell her to ask that. A couple of things. You don't do this at the very end of the session. You want to give about at least 10 minutes to have them fill it out and then have a brief discussion. Now, in general, most of the time, they're scoring you quite high. And, lost my train of thought. They're scoring you quite high, and the way you preface this is you say, and at least what I say is, I'm not interested in perfect scores. You could say something, I feel like things went pretty well today, but I really want to get better at this. And so, you know, it might be something kind of small. Even if you think it's too small to even mention, I'd like you to bring it up so we can talk about it and dismiss it together. So your professor said that soliciting and responding to feedback, you know, we talk about useful skills to learn. That is a very useful skill. How to, and I think it's coming up in the next slide. So I don't know if I answered your question, but you very definitely want to engage them in this discussion rather than give it to them and have them fill it out and bring it back the next time. Because the immediacy is very important. And communicating to them that you won't take it personally is very important. And in essence, learning to not be defensive. I don't know how much, am I able to go over a few minutes? Or?
Yeah, actually, can 3 to 5 minutes okay? Because we have, one thing I noticed in this agenda is that she just have it back like 11:30 and at 11:30 there's another event, so there was no time to walk.
There's overlap.
Yeah, you're fine. And if people need to go, they can.
Okay,
They can.
people need to go. So I was going to tell a brief story about feedback, and so I facilitate groups, residential addiction treatment. They're small groups. They're 6 or 7 people, and I work pretty hard on trying to bring an engaging topic. And so a few weeks ago, I brought this topic where I told the clients, it's actually some of the research data that said that there really wasn't a therapy method that was better than others. In the programs that I'm working in, people are really excited about EMDR. Some of you probably heard about that. Yay, go EMDR. Anyway, and EMDR may well be very effective, but there's no evidence that it's more effective than other kinds of other methods of treatment. So I came up with this lesson where I told the clients basically that it didn't necessarily matter what method their therapist was using in their program. It was more about the issues that they brought to the table. And my maybe naive way of thinking about it was that was going to be empowering to them, that they would sort of realize that they're the ones that create the change. And we had and the session went really well. I felt like people were really engaged. And there was a young man there who had usually given me pretty high scores on this session scale. He rated me quite low. And so I asked him afterwards, I said, what was going on? He said, well, you know, you just told us that we're the ones that are responsible, you know, that it's all about us, and we already knew that. You're a doctor, we want you to talk about neurobiology. And, you know, at the moment it was like, oh, you know, I worked really hard on you know, what I thought was something that was going to be good for you. And it wasn't what he wanted. And so the following weeks, you know, I leaned more towards neurobiology, and the guy was super engaged. And the fact that I asked him and I held back getting defensive about it, I think really cemented the alliance that I had with him. Does that make sense? Okay, so the same kind of thing, it takes a minute or less. We already talked about this towards the end of the session. Leave time for brief discussion. And kind of the most surprising thing is, for clients, is most of them are not used to being asked about how the therapy's going. you know, if they're asked, it's, you know, was this okay for you or something? Oh yeah, it was great. Not specific questions. So, feedback. It's the only way you can get better at something is to get feedback. It's critical for expertise. It's crucial for adjusting. And this skill of getting feedback and responding to it is a really important skill. And the idea is, and here's quiz question number 3, which is, so what do you think is going to have, which therapy situation is going to have better outcomes? A relationship that starts good and ends good, or a relationship that starts bad and ends good? Which situation, number 1, good, bad, good, number 2, is going to have a better therapy outcome?
I will say number 2.
Number 2. So it's responding to negative feedback with some kind of adjustment. That's very important. It's a great way to cement a relationship. So I gotta rush through the rest of this stuff. So what I've learned, if you create a culture of feedback, if you don't get defensive, you will get feedback, and some negative, but that's okay. It's a different kind of confidence that you get using feedback-informed treatment. It's a confidence that you're getting better at listening to the clients. It's a different kind of confidence that I know how to fix this problem. I feel like I was very automatic for much of my career, and I wish I'd learned about it sooner. The thing about getting negative feedback, and if you take it personally, that probably won't tell you it again. You know, you get one chance to, or you know, you can get several chances as long as you don't take it personally. We already mentioned acknowledging and responding to feedback strengthens the relationship. In the programs where I work, I'm kind of going it alone. You know, feedback-informed treatment's been around for a while, but not a whole lot of people know about it. So it's a lot of, I mean, I have mentors, I have some other colleagues that I bounce things off of, but it's going to be nice when the whole world is thinking about it. I value the curious part of me more than the confident part. So this is we're almost done here. You have a gift. You're asking those questions that I listed up there. There's lots of pressure to lose what you got. There's lots of pressure to develop competence and expertise. Stay curious, because curiosity is the foundation of multicultural competence. Curiosity keeps automaticity down. You can start your career using feedback. If it becomes automatic and second nature, there's no question that your clients will benefit. Eventually, I believe this is the way that therapy will be done. And practitioners who pay attention to their clients' feedback actually help 50% more of their clients. So, I have a few suggestions. If you want to look at the simple measures that I use, you go to the website. It's called scottdmiller.com, and I think you'll be able to find your way there. Just asking for feedback from clients and discussing with them will change things for you. I don't know, what the opportunities at Sac State are for using measures or supervisors who are sympathetic, but you should ask. As far as focusing on skills, it's the relational skills. It's the difficult conversations and certainly soliciting feedback. Structure the beginning and ends of your session around feedback. Be open to being surprised. Be wary of being too confident, too automatic. And there are such things as fit supervision groups. There's a particular way of doing supervision with feedback informed treatment. And this is how you get in touch with me.
Thank you.
Thank you.
Yeah, I feel like this is how it should be in therapy because when I'm with a client, sometimes my supervisor asks me, why are you asking that question? Are you asking to help the client? Or are you just being curious? So sometimes I said, and my supervisor would say, I feel like you asked the question just to be curious, but because I'm curious of what the nature of the situation is, so I can better understand to help my client. So this is like the missing link that I was like, yeah, why can't we be curious? So curious, that's really good because I have many questions.
There is an entity called the International Center for Clinical Excellence. And if you do a Google search, it's a group of people who are interested in feedback informed treatment. They have it's on Facebook, but they do have a group where there are cases that are discussed and the measures are discussed. So if you look up, it's called the ICCE, International Center for Clinical Excellence, and it's a super good resource. And feel free to email me. I answer all my emails. Enjoy your weekend, enjoy your spring break, enjoy the rest of the